Okay, if you haven't heard us discussing it, we are waiting. Yeah, watch those long fingernails. We're waiting for a quorum. We're waiting. Okay, well, while we're waiting, I see.
There's Teddy.
Teddy, it's about time.
It's about time.
You get the prize. You make the 10th person.
Oh, wait a minute. What about the prize for the people who got here early?
I'll work on something for you too.
I object to that.
Okay. I'll do what I started. What are the White Jackets? Where are y'all from?
We're resident physicians at Wellstar.
Oh, okay. Are you in the wrong committee? I heard there was a little discussion about something going on that might influence, that Wellstar might have had something to do with. And so we're glad to have you. You're all from Georgia, and you're all going to stay in Georgia, right? Is that true? What's your specialty? Nod yes. What is this prompting? We do have a doctor shortage, and one of the problems is when residents go out of our state, they sometimes tend to stay out of our state, but you're already here. So hopefully you'll find a home after your residency. What are you, family practice, OBGYN? What are you? Dermatology, okay.
Radiation oncology.
Thank you for working with our cancer patients. It's so important. Radiology, thank you. I mean, everybody's important too. We just had somebody have her cute little nose worked on because of a skin cancer, and it looks down on the end. She has her cute little noses back thanks to a dermatologist. So all of the specialty of medicine are very important. My husband was a family practitioner. He's passed away. So I know the sacrifices that you make, and you are appreciated, even though sometimes we don't say it enough to our residents, to our medical students, to our doctors. Okay. I will officially call this meeting to order, and this will be our very last meeting for 2023, and we're going to go out with a bang. We have a brand new senator to present to us, and so Senator Echols, come on up, have a seat. If you need your friend with you, come on. Nope, not that I think you do. So, and I want to thank you for working with us. We have attached a bill to Senator Echols' bill, which is very important to one of our members who has had cancer right now. I think she's probably in remission. It's not something, and I hope that remission lasts forever. But Senator Echols was nice enough to let us attach a bill that is very important. And I think everybody on our committee knows, to Mandy Ballinger. And so thank you so much for being willing to do that. As you probably know by now, you didn't have to do that. Whoever owns the bill has the right to own it. And so it is really, we really do appreciate it. So go ahead and tell us about, especially start off in the back if you want to, with what is really your part of the bill.
Okay, certainly. The back half is my bill. I think it's section 2, and it's the shorter part of the bill. It starts on page 5. It had a companion bill that passed through the House Bill 143. It's a continuous glucose monitor for Medicaid patients. The bill originally moved it from a durable medical equipment to a pharmacy benefit. But now, after consulting with the governor's office and DCH, we've changed some language in there just a little bit. And it's on, well, let me see what lines it is in the new bill here. It'll be lines 121 through 124. That language change came about a few weeks ago when this committee unanimously passed similar legislation. You guys passed it through in HB 143, and that reflects our working with the Department of Community Health and the Governor's Office to provide the department flexibility in establishing the most cost-effective delivery channel for continuous glucose monitors. So this bill still allows patients to use their primary care physician to obtain that medical equipment without having to see an endocrinologist, because you all know we're in such a shortage of endocrinologists in Georgia. So this does open it up, the channels, and makes it more convenient for those patients, but also a little quicker too, so they don't have to stay on those waiting lines. What remains unchanged is the language of the bill to update the coverage criteria, and it really creates better health outcomes for our diabetic Georgians on Medicaid. I hope you'll give favorable consideration to this updated language so we can pass it through the House, get an agree in the Senate, and have it signed into law. I'm no expert. I really just saw the first section of this bill, so I'm sure you can speak to that. Yes.
Okay, I'll help the senator out. What we did is added information on white bagging to make sure that patients were put at the top of the list when it comes to how we are going to deliver medicines, mainly for cancer patients, to deliver their high-powered cancer drugs. When a patient has cancer and has been diagnosed and needs to have infusions, the usual routine is they will see their doctor each month or every 2 weeks, however it's ordered. And the doctor at that time will do blood work before they allow the patients to have an infusion. If their blood work comes back that it's okay, that it's within enough of the normal limits that they can tolerate the medicine for the cancer, they will then send them to an infusion center. It might be in the hospital, or it could be that it's a big oncology center and they have their own infusion center. And at that time, their medicines will be mixed up by a pharmacist and administered very specifically to that patient at that time. Some of our insurance companies now also own pharmacy chains, or they have their own pharmacy, and they decided that they wanted to mix up or do these medicines for our cancer patients. Well, we're not talking about local pharmacies. We're talking about pharmacies somewhere, wherever. And they would then mix up the medicine and by some means get it to the patient. That might be through the mail. I guess you could UPS it, I don't know. But they'd have some way to get them. And the problem with that is, okay, let's say they mail it. What happens if the patient has an appointment for the June 1st and the medicine arrives on June 2nd? Cancer patients are very regulated about how many days between each cancer treatment. And a lot of times it's very hard for them to vary that and have their insurance pay for it. What happens if it comes to a little lady in South Georgia who's getting a little forgetful, but she's getting her cancer treatment and she's gotten her medicine through the mail, and she goes, oh, I may forget that medicine if I put it in the house. Maybe I better put it in the car so I won't forget it. And the problem is the car sits out at 100 degrees. I mean, this is one of the problems, that our medicine's delivered from some way. Or that thing is that the patient gets there with the medicine and they get their blood work done. And their levels have dropped too much to allow them to have that treatment. Who pays for that? Because it's not going to be something most likely they're going to get the next day. They probably will have to wait 2 weeks or another month or a period of time until their body builds back up to where they could tolerate a medicine. So there's lots of problems with that. And patients are being forced, in some incidents, to submit to having their medications this way. I will say another thing is that we're even trying to make it more convenient for patients in rural areas of our state to get their medications. Some of our hospitals here in the metro area are working with hospitals in rural areas around our state to have infusion sites. This not only helps the patient, but it helps the small hospitals around our state, where they may come to Atlanta, to Emory, to the Winship Cancer Center and be diagnosed and see a physician. But then after they get them as stabilized as they can be, maybe the monthly treatments are seen, they would be seen by a physician in their own hometown or nearby, and they would then make sure that they could have their infusions, and the infusions would be given in an infusion center in those hospitals. So that's basically what we want: the patients to get the right medicine in the most efficient way that's done, where we're sure that the medicine is the safest and that it has been at the right temperature and it's for the right patient and it's the right medicine. Anybody want to question, did I hit it hard enough about white bagging? Anna, do you have anything you want to say as far as how I, come on up and what you want to say in my process of saying how white bagging?
I think you did it perfectly. Thank you, Madam Chair.
Of course, what can you say? But other than that, no, it's all right.
I would tell you, I'm generally pretty honest. Thank you, members of the committee. I'm Anna Adams with the Georgia Hospital Association. We are very much in support of this language and very appreciative to Senator Eccles for including it in this bill. You have at your seat a one-pager from GHA that explains what the white bagging process is and what it looks like if you were to have to go through a process of white bagging if you were a patient and what those delays are. I can say that as we have considered this measure over the last several years, we've come at it from a little bit of a different perspective this year because over the summer we did work closely with the Office of the Commissioner and Fire Office. I'm never going to get that right. The Insurance Commissioner's Office to figure out if they could do this via executive order. And it turns out they cannot, so we had to come back this year to ask for a legislative fix. We have tried to make it as loose as possible so that if in a contract negotiation a provider and an insurance company want to use a white bagging scenario because it's what makes sense for that community, that they would be able to do that. If a patient wants to use a white bagging scenario because it triggers a different deductible for them, absolutely allowed. It just prohibits the insurers from requiring, if you are already in network, that the white bagging situation be forced upon them. So I think this kind of speaks for itself. We've gotten a lot of feedback from hospitals that are providing these important infusions for their cancer patients and chronic disease patients, and I think you'll hear from some of them today, but I'm happy to answer any questions if there are any.
Stick around. I don't know whether the questions are for you or for me, but the board is lighting up. Let's see who's first. Representative Perkle.
Thank you, Madam Chair, and I'm not sure who it is either. And I don't want to get into a conversation of the definition of is, but when you say required, so here's a concern I have. So if I'm an insurer and my patient needs an infusion of compound AB, whatever that might be, and I have two options. I can send it to them or they can get it done in the hospital. Studies have shown that the hospitals can cost up to twice as much as, the study I showed twice as much, or an average of $7,000 more than purchased through specialty pharmacies. So if I'm an insurer and I have the same drug, AB, that I can send for them to be administered, or they could go to the hospital and get AB, and it costs double or $7,000 more, I'm going to say as an insurer, how about let's do it the cheaper route? And so the needs of the patient absolutely are up at the front, but we also have to look at costs. So when you say that in this bill that it is not required, and I'm looking at say a $7,000 difference between the white bag thing and what you do in the hospital, and I'm an insurer, I said, hey, I think maybe let's do the white bag thing. What prevents in this bill from me doing that, or the insurer saying, absolutely not at the hospital?
That's a fair question. So the way that this is drafted, if a patient is considering their own personal costs, they have that option to choose between the white bagging option through their insurer's specialty pharmacy, which they own. The insurers own these specialty pharmacies. But if they choose to do it, it's not always a hospital. Sometimes it's an infusion center where their provider practices. That's also allowed. Typically, though, the patient portion that they have to pay, so their deductible and their coinsurance, is the same across the board. When you have these infusions at a provider visit, often for these drugs, because they're very expensive, there's a provider or a manufacturer rebate through the pharmaceutical company. When we get those at the provider level, we apply that to what the patient owes. When you are looking at the cost savings for the specialty pharmacies, they are taking that drug rebate and keeping it. It doesn't go to the patient. So where you're seeing that realized cost savings, it's including the drug rebate number.
The patient has the choice. It's, you know, if they
Well-
want to, if they want to accept the white bagging thing, they can.
Okay. Well, and there again, so if I tell my son, listen, I'm gonna buy you supper tonight, I'll buy you a hamburger, and I'm expecting him to go to McDonald's or Wendy's, and he winds up going down to the Ritz-Carlton, it's still a hamburger, and it's what I promised to do, but my preference is, if I'm footing the bill, that we find maybe a little cheaper alternative. I just want to make sure, because I don't know when it's not the patient's money, because either it's going to be reflected in my premium, or I'm paying out of pocket, or I mean, eventually we're all going to pay that. And so I don't understand the difference between the patient's cost versus the insurer's cost. If the insurer's cost goes up, mine's going to go up. I promise you. I'm not generally a friend of the insurance company.
Now,
Either,
are you on the
because-
insurance committee?
No, ma'am.
Oh, okay, just thought I'd ask.
No, ma'am. I am not. They don't want me there. I promise
I
you.
am giving you a hard time.
I promise you. That's why they don't have me on judiciary either. But so
No,
anyway.
insurance.
So if I could, I just want to add that this only applies for an in-network provider. So that means that we've already negotiated, we already have a contract between the provider and the insurance company. When we're doing those contract negotiations on the front end, if cancer, for example, is an included benefit, we are ironing out all of those details about reimbursement, whether or not we're going to use their specialty pharmacy versus our own pharmacy on the front end. If there's not already a network contract, this bill does not apply.
Okay. You got it? They have a negotiated price as a contract. And when it comes contract times again, they negotiate on all sorts of stuff. So they would negotiate again if the insurer thought that the price was too high during contract negotiations. It's open season on it to come to. You understand, Jody?
I mean,
You
why
just
is,
look-
why is the legislation necessary at all if there's already, if it's only in contract and if it's already a negotiated rate, therefore they should at least be matching or somewhat close?
Because when we already have existing contracts, the plans are allowed to do mid-year plan amendments, where in the middle of our contract, they can come back and say, we no longer want you to use your pharmacy for XYZ drug. We can get it cheaper through our own pharmacy that we own. And so you can no longer source it that way. What this bill does is makes it so that in your contract negotiation, both parties have to agree on the front end that either you're going to allow white bagging or you're not going to allow white bagging. And I can tell you that I have hospitals now that do use white bagging policies because they don't have the pharmacy resources to be able to store some of these specialty medications, and everybody is okay with that. But on the chance that hospitals feel more comfortable with some of these drugs because they have providers in-house, because they have concerns about chain of custody, and they want to use their own pharmacy, it requires that the insurer, if they're going to be in network, not force them to use the white bagging policy.
Representative Houston.
I was late, I was in another meeting. Why is this in health and not insurance? All we're talking about is insurance. Are we in the right committee?
Okay, you missed it. This is an addition on this bill?
Yeah, but I mean, I understand,
I-
but it seems to me most of the questions have been regarding to insurance.
Well, I'm just trying to let people, I mean, we'd already passed out, from a number of our House members, we had already passed out a bill that was, you know, exactly like the one Senator Nichols has. But she's being very nice, and we passed, I mean, the insurance company passed out a bill, but it hit
No,
that.
I just wondered if this was in the right code section since we were talking about insurance so much.
Apparently, you know,
It-
it's okay. It's okay.
Is Betsy in here?
It's a little bit of a stretch. I'm trying to tie them together by talking about access, giving patients access
To care.
drugs. So both, I think both pieces do
Eh.
that, one through Medicaid, one through private insurers. So, trying to tie them, but it is a little bit of a stretch.
And the next question, when you were talking about the little old lady from rural Georgia going to the hospital, well, if the little old lady went to the hospital and needed some Botox for a migraine, would it be cheaper to white bag or get it to the hospital?
This doesn't apply to those kinds of medication. These are infusion drugs where we see white
Only
bagging policies.
infusion drugs are a white bag,
That's
nothing
it.
else is white bag.
That's typically what we see, yes, ma'am.
Typically, but,
I have never heard of a white bagging situation for Botox.
okay.
And the bill did pass out, Representative Houston, and got, I think it was one of those bills that went over when, remember, the Rules Chairman said he got 55 bills on the last morning? And it did get out of the insurance committee, but it got hung up, and so, as we all do, and look for things to let it ride on, that's why it's over in this committee. Because it is, you know, it is a patient's safety to a large degree with these drugs and high-powered drugs and cancer drugs and very special ones for some rare diseases. It is a patient's safety in doing what's better for the patient. So it does make a difference with these drugs. Okay? I mean, all right. Representative Reese.
Thank you, Madam Chairwoman. I thought I had a coherent question, but now I'm not even sure with everything that I've heard. But I want to ask some follow-up, if you don't mind. Did I hear a portion of you talking about many insurance companies utilize these pharmacies because they own them? So therefore, they're making money off of their own subscription, whether it's delayed for the patient or not, right?
That is correct.
So what this law will do is say we're going to put the patient's health first. And if there is a private pharmacy that can handle it regardless of cost, because to me, cost is irrelevant when you're playing with someone's health. So what this will do is say if there is a private pharmacy closer to the patient to where they can get their medication in time to meet their next doctor appointment, then we should give that person access to that versus the insurance company saying, not only am I going to regulate the price, but I'm going to make you buy from my pharmacy so I can double my profit on it, right? Did I miss something?
No, I think you said it pretty succinctly.
Okay, well, Madam Chair, at the appropriate time.
Well, this is not it. We're moving on down. Representative Taylor.
Thank you, Madam Chair. I think I have a solution to some of the things that Chairman Perkel was talking about, and it would be an amendment, and it satisfies everybody, I think. And it does allow for white bagging. It needs it. I am a patient that does receive infusions, and I do want my medicine there when I need it. But there is a thing called 340B, and that is a way where drugs are purchased at a much reduced, and there are hospitals that mark that up 700, 1,000%. So I want to make sure it's fair. And what this amendment does, it says specifically that the insured network where the hospital has already negotiated, that's the price that you pay. And if you happen to be getting a newer medicine or something that has not been included in the network negotiations, then it would just agree that they would accept the wholesale acquisition, whatever the price is at that, and it will be then renegotiated at the next contract. That keeps it all kind of, it's a guardrail, and that's what we were looking for, so that drugs cannot be marked up substantially. And they're all important, and the patient needs them, and this little amendment would do that.
Madam Chair, as hospitals are considering setting their prices, we do have to do a charge master, and every patient has to be charged the same, regardless of whether they insured, uninsured, et cetera. That's a CMS federal guideline. With regard to the ability to mark these medications up, we cannot one-off mark up a drug for a patient who is insured versus a patient who is not insured. There are lots of federal rules and regs about that. My concern with this amendment language would be that if there is a default payment option of a wholesale acquisition cost, it would remove the incentive for future negotiations because the floor is there, and it's a very, very low floor. As I mentioned, this bill only applies when you are already in network, and for patients who are receiving infusions that are not a part of our drug formulary and are not considered, we have to get a prior authorization for all of these infusions anyway. These are very expensive medications, and often patients have had to fail multiple drugs before they even get to this point. So the insurers are telling us on the front end, yes, you can do this drug, or no, you need to try a different drug. And we know on the front end what they're going to reimburse us. Finally, we can send a bill to an insurance company, but it doesn't mean that's what they have to pay us. And we see that often, where they reimburse us much lower than what the billed amount is. So really, the ball is in the court of the insurer ultimately anyway.
Well, and I think that one thing that's been lost here, when we talk about the insurance companies shipping the medication, we're talking about one thing, that the medication is being shipped or however they're getting it to the patient. When the hospitals or an infusion center mix up the medicines and give them to the patient, patients usually sit 4 to 5 hours for an infusion. It's not uncommon. I have toured recently the Winship Center and another, cancer insurance. They have a whole, room for infusion for the patients and so forth. The nursing ratio is about 1 RN to 4 patients. Because these are such high-powered drugs, people have reactions to them. They have to have a cart. What do you call the cart? When you got an emergency cart ready to think like that. I mean, this is not, your average floor. There's a lot that goes into paying those nurses and running an infusion center that also adds to the cost at the hospital, or to the infusion center. So it's not just the medicine, which if you own the pharmacy or, you're sending it from a pharmacy, you send the medicine out and that's where your responsibility ends with it. It's the other part of administering it and to the patient, so there are added costs about that. I think I'm going to use my prerogative. I've seen that amendment. I've talked to them. I have great respect for you as a chairman, and I think that you know that, but I'm not going to accept that amendment to be brought forth. Representative Dempsey.
Thank you so much, and thank you, Senator Eccles. I know we're in a challenging time right here, right? I had a bill over in the Senate that a lot of people became very popular the other day, so I know how this feels when something wants to became very popular.
You're not alone, Senator.
Yeah, we're all dealing with that. So, but I just want to clarify because I was in another meeting trying to get here. So, so GHA is opposed to it, but Shepherd Center is supporting this. Or
No, ma'am. We are opposed to white bagging as a concept, and this bill addresses white bagging. So Shepherd Center is our member. We are all in support of the language that's contained in Senate Bill 109.
That was what was confusing me, just looking at the two pieces here. But yeah. So whenever you're ready, I know you have someone that's already offered, but when you're ready, I would certainly support this.
Thank you.
Shepherd Center. Is there somebody from the Shepherd Center here? If you want to speak to it, I knew there was somebody.
If you're pushed for time, we're in support of it, but I'm happy to also share.
And they had a letter too that came in late in support of the bill, like that. And I will tell you that it did pass out of the insurance committee without that amendment on it. So that is something. Representative Lott.
I waive.
Okay, thank you. At this time, have we gotten everybody? Anna's talked about it. Abigail Thompson.
That's me.
That's you, okay?
We're in full support. This is a big issue for us. We operate an infusion inpatient clinic because we treat MS. So this would greatly help us. And again, it's about patient choice. So.
Okay. Joel Tuss? Truss?
I'll just say we have a standalone infusion center and a cancer center. This will greatly help us and our patients. And I'll come to the mic on this point. I know my voice carries, but
Right.
yes.
And you're with?
I'm with Tanner Health System
Tanner.
in West Georgia. We have a healthcare organization there that services Bremen, Villa Rica, and Carrollton. And I just wanted to address one quick point for Chairman Perkle. I understand your perspective. Our perspective on this is simply that by limiting the options to one area or forcing that limit on providers, instead of having McDonald's, Burger King, or the Ritz-Carlton, you're going to Burger King. This simply opens up the options to have that choice. And we think that'll be overall better for the patient.
Okay.
Thank you, ma'am.
Who was this one? Michael Power. Huh? Oh, sorry. Did you? Okay. Go ahead, Representative Perkle. Sorry.
Can I ask him a question?
Sure.
Madam Chair?
Sure.
So I just
For my
want to
friend,
make
of
sure
course.
that I understand. Yeah. So you bring me up, and I'm going to ask another question.
Yes, sir.
My concern is appearing from the hospital's perspective. They feel like the insurance company is vertically integrated and is using their power to make things more in their favor. I want to make sure that these infusion centers that you own and the pharmacies that you manage and the profit that you're going to make on these things, that we're not sending another silo up that would create economic disincentives for price drops.
I understand.
So I love competition. I think when you introduce competition that the prices go down. I want to make sure that we're not swapping one silo, in your opinion, for another one from a different perspective.
I understand, and I believe that it wouldn't do that for a few reasons. As I already mentioned, we have several federal guidelines that restrict exactly what we can charge. And for our hospital especially, most of those infusion and treatments will go to indigent and Medicaid patients. So it has a very fixed price already. It's not going to be a situation where we gain here. It will simply be, especially as a standalone and a 340B pharmacy, we would simply have the greater options for the patient, mostly to make sure they get their infusions and treatments on time. That is an issue that has come up with white bagging several times with us, and we want to make sure that it's timely and cost effective.
Representative Lott, you waved a while ago. I'm going to give everybody one chance. What did you?
Really is the same question. I'm sorry. I want to follow along with Chairman Perkle as well. Just 2 points. Are the patients actually given that as an offer, or is it a silent offer? Basically, we're not saying what we're doing in this legislation is we're making it so that the insurers must pay. But was the patient ever given the offer? Because I know in my own healthcare practice, it's very much that way with some places where patient can go anywhere. We just don't tell them that. So therefore, we just keep sending them where we want to send them. Okay, but at some point they find out, you mean I could have always requested to come to your facility? And the truth is yes, but no, they're never going to tell you that. So does the patient know that ahead of time? And is anybody making the cost differences, putting that out there as well?
For us, our patients currently do not have that option, mostly because we do not have the option to give them other cost options. That is strictly controlled by the person who is filling the prescription, which, as you heard, is usually the insurance company. Now, if this bill were to pass, that opens up the options a little bit more. That gives them a chance to see, okay, I can get the insurance option if necessary, or my hospital has it in store, they mix it, they can do it as well. So it's one of those situations where we cannot provide it because we're not usually the ones filling the prescription. That goes into the circuit and into the insurance-owned pharmacy.
That answer your question?
Yes, that's fine. Thank you.
Okay, Representative Taylor, I'm going to let you have the last.
Thank you, Madam Chair. I want to thank the senator for her patience as we discuss, and to make sure everyone knows nobody likes white bagging, and that is not a good thing. Just looking for guardrails. But thank you, Senator, for your patience. Thank you, Madam Chair.
And you get to see what health is like. I joked a while ago that people were scared to come on a committee when I wouldn't get in a quorum. And I think it was just a joke. I hope so. Anyway, although Speaker Ralston did say when he came to this committee one time a couple of years ago that, and teased us about the fact that he hadn't been there before, perhaps because it was a hard committee. We just tend to be thorough. Okay, I think we've had a discussion on the amendment, and we don't need to go into it in any length, but Jesse, if you want to have about 1 minute. I mean, we know what your side of the story is.
Yes, thank you, Madam Chair. My name is Jesse Wethington. I'm here as the President and CEO of the Georgia Association of Health Plans, which is the trade group representing the commercial health benefits industry in the state. My comments are reserved to the white backing portion, not Senate Bill 109. We have several issues with this bill. That's why we offered the compromise amendment. But as you said, that has been discussed, and you're not going to entertain it. As you've heard, this issue is really about, it's not whether the patient gets their drugs, it's how much they charge for it and what they end up paying. The markups can be eye-wateringly significant. We do have to make difficult choices about stretching the healthcare dollar. Prescription drugs is the largest and fastest growing segment of the healthcare cost issue, and this is in response to the cat and mouse game that we play with the providers that in the previous several years, a lot of the oncology practices have been purchased by hospital systems. Previously, those have been outpatient facilities. They would have been charged lower prices. When the hospital acquires that oncology practice, it becomes an inpatient facility, and as you know, Madam Chair, well, the prices tend to go up at that point. This is a response to that so we can drive affordability for our members on these very expensive drugs.
You don't want to get me started on the insurance companies. I think this committee knows that besides judiciary, people don't like to go to insurance. And, I've been there, when the insurance company has wanted people to fail on medications twice before they get the medication that they really need and other things, and we've had to pass laws to take care of that. I think this is one of those situations, but that's my personal belief. And Mandy, if you would like to speak, I think I've already, sort of said, and I hope you don't mind, that this bill is of great importance to you because of your personal experience. But come wherever are you comfortable where you are?
I just want to say thank you. Thank you to the chair. Thank you, Senator. I am Mandy Ballinger, representative in the Georgia House of Representatives. As many of y'all are my friends, but it really is for me. My personal oncologist reached out to me, and several friends kind of in the cancer community reached out to me about the potential dangers to cancer patients, and that's how I became so involved in this bill. Obviously, health is not my wheelhouse, but I really appreciate the chair lady's indulgence and perseverance in this matter, as well as the senator's patience and indulgence.
Well, we certainly appreciate your determination to overcome your hard time and to be back here serving with us and being one of our colleagues and part of our legislative family. And I appreciate the doctors, whoever they are, who have directed your care and made you back and looking like you're practically in the best of health and moving a lot better than years ago. So thank you. Okay, moving on to the committee and what their thing is. Teddy, you ask, and
Madam Chair, I am honored to move this bill on behalf of my Leadership Georgia classmate, the best class ever, 2015 Senator Shelley Echols. And as it relates to Senate Bill 109 LC 339516S, I move that this committee do pass.
Dempsey, you wanted to second it?
Leadership Georgia class that was there before y'all were even born. Yeah. Yeah, it's my privilege to second it.
So, is there any further discussion on this? Don't see any lights light up. Okay, everyone in favor of the passage of, where's my bill? What, like that? The substitute to Senate Bill 109 as amended, say aye. Okay, anyone opposed, no? The ayes have it. Thank you very much, Senator, for sticking with us. Come back to health again sometime next session.
Thank you all. Can I get your signature?
Sure. Okay. Okay, can I get the committee back together again? All right. Okay, no. Okay. Okay, if we can get our committee back together. Okay, Representative, that's all right. Representative Bazemore has had a bill that she's had for several years in my committee. And I said that I would give her a hearing today. And I don't know whether you heard me or not, but she is probably still at the hospital with possible heart trouble. And that's why I was joking about, I knew that people were scared to come to this committee, but really, you know, going to the hospital with a heart problem, you know, seems a little bit much. She could have talked to me about it. So who is going to present it? Okay, Representative. And I'm batting down the forces, boys. It's about girl things. So, and I tease the committee because anytime we talk about breastfeeding or anything, the boys usually get a little nervous, but that's okay too.
Not a lot of time, yeah. Thank you, Madam Chair. Thank you, members of the committee. I am presenting this bill, obviously, under circumstances that I wish I was not having to be here to present this bill. So I really do hope that Representative Bazemore, my colleague and friend, is feeling better. I'm presenting House Bill 358, LC 339189. This is a bill that simply does two things. Number one, it adds HIV prevention instruction to the sex education code. And number two, it adds best practices for and risks associated with tampon use, specifically the development of toxic shock syndrome. So really quickly, this just clarifies that HIV prevention shall be taught in sex education. Currently, we only require AIDS prevention. However, it's important to note that HIV and AIDS are not the same thing. And in fact, with advances in medicine, many people living with HIV live long, thriving lives and do not progress to AIDS. Still, it has been a goal of at both the national level as well as the state level to eradicate HIV. And this is actually really important here in Georgia because Georgia leads the nation in new HIV cases. And so that's very important. I do believe an ounce of prevention is worth a pound of cure, and education is one way to prevent. This bill also is related to educating students or patients on the risks of tampon usage. Specifically, it requires notifying students of the risks of toxic shock syndrome, which is a bacterial infection associated with tampon usage. I do want to be clear, this is rare, but in cases where it does happen, it can be fatal. And so that's why this is important. And it also encourages any healthcare professionals who provide tampons to their patients to provide information about these risks. And like I said, risk being that while this is something rare, and through advancements in just knowledge in the field of microbiology, we've been able to pretty much eliminate this. It is not gone, and in some states they're actually seeing a resurgence. And so it's important that we provide that information so people know and can make good, informed decisions. And with that,
All right, I have a question. This has come up on the floor of the House the other day. You're saying that we already have in the curriculum to teach about AIDS. Now, you know, I know the difference between HIV and AIDS. What is and I know you're doing this for Deborah, but what is the difference in what the curriculum would be? What you would teach about AIDS prevention and HIV prevention?
so that's actually a very good question, and actually that part of that language is actually in a bill that I've proposed many years as well. So I'm glad you asked that question.
Me too.
When it comes to AIDS, AIDS is in stage. It is advanced. acquired immunodeficiency disease. Basically, your immune cells have been depleted and you can't fight off normal infections the way most people can fight off a normal infection. A lot of times in some of the curriculum here in Georgia that is used, the way they teach AIDS prevention is by saying, if you don't have sex, you won't get AIDS, you won't die. However, that skips a whole section of HIV, which is there are a lot of ways that we can prevent HIV, and also just teaching about things like PrEP and all of the other interventions to decrease the likelihood of people getting HIV. So it is very, very, very possible. It is very possible to teach about AIDS and skip HIV, and skipping HIV it's really important because we can't eradicate it if we're not even talking about it.
Okay, so you're basically saying the way that the schools, if it's in our curriculum now, it's basically just saying the same thing as abstinences, I can't say it, never have been able to, that just not having sex is how they teach, that's how you take care of AIDS.
In some of the curriculum that is used across the state, that is pretty much how it is presented, is basically not being hyperbolic. This is how it is presented in some places. Having sex, if you have sex before you get married, then you will die from AIDS. And that's pretty much all that you have to say according to this curriculum. And that's how it is presented in some places. And that's unfortunate. This will at least require a level of biology to go into that instruction so people really, truly understand the risks.
Okay, I can't wait to hear what's going to come from Representative Perkle next.
Okay, so there was a challenge that the boys would remain silent on this one.
I would love to hear from you.
I just told you to get ready for this.
From the lady who loves a question at any opportunity, I must absolutely provide a question now. Finally, tables are turned. So help me understand with two questions, if I can. So the first one regarding the HIV/AIDS deal. Am I right in assuming in a Venn diagram of HIV at Georgia Tech?
What, did you learn Venn diagrams for the vice president of the country?
So, well,
she loves them. Do you love them too?
I didn't know how. I don't listen to her much. I have no idea what she's got with that, but we did learn that at Georgia Tech. So if you looked at a Venn diagram with the outer of HIV, am I not correct in assuming the Venn diagram of AIDS would be wholly encircled within the Venn diagram for HIV?
So, yes, if you want to simplify it. However, as I said in my presentation, every person that gets HIV does not get AIDS. In fact, with medical advancements, lots of people go on to live very, very, very long lives without ever advancing to AIDS. And so that's really important because teaching sex education as a doom and gloom situation instead of being biologically and medically accurate and teaching it in a way that says you want to prevent getting HIV, not just because you want to prevent getting AIDS, but because we want to, as a state, not lead the nation in HIV cases. But we can't do that if we're not even talking about it in the classroom. So number one, when we use the word AIDS, that's really outdated language. Most public health systems, public health departments would say that it's much more accurate to talk about HIV. And again, we eradicate HIV. So to your point, if we can eradicate HIV, we can eradicate AIDS. But I think as a state, we should be pushing for decreasing the number of HIV cases. So we have to talk about it. And that's what this would do. So we're already talking about AIDS, but let's add the HIV component in there so that we're giving students the
I don't see how you talk about it, if I may, Madam Chair. I don't mean to talk around you. But yes, ma'am.
Family discussion?
So I don't know how you talk about AIDS without talking about HIV.
I would agree with you unless I didn't know for a fact that that is done in classrooms right now. They
So
completely
my mom
skip.
retired as a health educator, and I sent all three of my kids. They had the unfortunate experience of having their granny give them the talk, if you know what I mean. So I do know a little bit about this, and so I'm just a farmer, but I do know about this regarding the tampons, the Section 2 part of the bill. So this is in a hospital. If a physician or a nurse in the hospital provides a tampon to a female patient, then they must provide written stuff.
Yeah, like a pamphlet. So a lot of times, if you've ever bought a box of tampons, maybe for someone in your family, you'll know that inside of that box there's a pretty extensive pamphlet that tells you how to use the tampon, but it also talks about the risk of toxic shock syndrome. This would be the same. So if you're in a hospital setting, you might not be getting a huge box of Tampax that has the pamphlet in it. This would just say, still provide that information to the patient if you're just handing like a single-use tampon without the insert.
So just for the record, while I have bought those products, I've never opened them up to see the pamphlet.
Representative Howson smiling again. It's good to see. Representative Hutchinson.
Thank you, Madam Chair. I want to let Representative Hudson laugh some more. I went to Catholic school, and the nuns told us that if we kissed a boy, we were going to hell because it promoted impure thoughts in the boy. So I appreciate any specific scientific education that we can give students in Georgia. And on the toxic shock syndrome, I had a mental health patient that was in children's health care for a week. She was 16 with toxic shock, and it wasn't that long ago. So I do know that it is still a thing, and it's still something that we need to make sure girls understand.
It's gonna get
We're
better.
talking about tampons. Where are you going?
I understand. Okay. I mean, we're laughing, but we know that, we don't mean to. Sometimes you just have to laugh a little bit to ease the tension. So anyway.
Well, I just wanted to say that.
Okay, Representative Al.
You keep telling me to lighten up. I'm very lighthearted in this place. I think basically what this bill aims to do is something you explained very well, which is to modernize our approach to teaching the specifics of and the prevention of HIV, right? And I think that the point you're making, and isn't it true, that the point you're making is that we cannot teach it as a binary as we have back in like the 80s and 90s. Like when I was growing up in New York, we were taught that it was a yes or no, but this newer approach to HIV treatment and care is that we are treating it like a chronic disease. And there are many aspects to it and many qualities to how we approach this that deal with prevention that people need to know, right? Especially in a state that has the highest new percentage of HIV cases in the country, that talking about PrEP, talking about perinatal prevention, talking about antiretroviral therapy, these are all parts of the discussion that we need to have, and it isn't just a binary of you're HIV positive, you're not, because that leaves out 95% of the information that people actually need.
Right. The point is there is a big bridge between abstinence and AIDS. And we need to fill that gap. And that's what the first part of that language does. And secondly, when it comes to information, I don't think we should ever scoff at providing information, especially information that might save someone's life, on the part about toxic shock syndrome.
Okay, Representative Anelowitz.
Thank you. Yes, so this is related to the tampons and the toxic shock syndrome aspect of this bill. Several years ago, and this happened after there were several natural disasters, after Hurricane Michael and other tornado issues down in South Georgia. And one of the things that the food banks that were working down there realized was that in addition to a need for food, water, essential supplies, there was a need for menstrual supplies for the women and girls who had lost everything. And one of the problems that the food banks, and I'm just checking my notes, which is why I'm looking at my phone, one of the problems that the food banks found is that they weren't able to distribute, like they couldn't, if you had it, they had to distribute entire boxes of tampons, not just a supply of like maybe 15 or 20 tampons if it's a box of 40. And they had a lot of problems distributing those menstrual supplies because they were told they couldn't separate the tampons from the instruction pamphlet. This was a crisis situation. It was, these women didn't necessarily need an entire box. And frankly, to give everyone an entire box was going to limit how many menstrual supplies they were able to distribute. So these food banks were able to get permission to distribute these tampons without this kind of information. Would this legislation preclude that from happening?
So the way it is written, it does say healthcare professionals, so specifically doctors and nurses. So in that situation, I'm not so sure that it wouldn't, they wouldn't be able to do that. Apparently, in their opinion, they already couldn't do it. And so that's an interesting
But now they can,
point.
right? They have permission to do
Yeah.
that now. And would this preclude anyone who wasn't a nurse, like a school nurse or a nurse, from giving people menstrual
So
supplies?
This encourages. So it doesn't require, it is an encouragement to provide the information. So it does not say that you shall require or you shall give the written
Okay.
information. It is, they're encouraged.
Because that was
to do
there were a lot of obstacles to making it so that
Right.
the food banks could distribute these menstrual products.
No,
And I
that's
wouldn't want
very
anything to
important.
happen that would prevent that from happening.
Agree, and that's very important. So it's more of an encouragement. It's not a requirement.
Thank you.
We got two more, Representative Reese, and then we're going to let Representative Taylor end it.
Thank you. I was hoping to have a little fun with Chairman Perkle before he left, but
Aw.
I also wanted to, if I can get like someone to share like what exactly is toxic shock syndrome. I know we got some doctors here. If one of you guys volunteer to come up and tell us from
I
a
can
medical
tell you as
perspective.
well as a
But, okay, well,
microbiologist.
that's right.
I mean,
Doctor right
we-
here too.
We have our own doctor here, but would y'all like to do a little impromptu? No? We have one female. Remember it from before you started dermatology?
So as a microbiologist, I can briefly tell you that it is a bacterial infection. Usually it's caused by either streptococcus or, so think strep throat, or staphylococcus, so think like staph infection. And these bacteria release a toxin. And so when it releases that toxin, this actually causes the body to go into shock. And when you go into shock, your blood pressure drops so low that your heart cannot adequately pump blood to get it through the circulation. So it can be deadly if not treated very, very quickly. And so it's really...
What time frame are we talking about with this transpiring? Like, is this like after a few days or a week or a month or?
Usually, if you start having symptoms of shock, you are at a point now where you need to be in intensive care. So this can happen pretty quickly. So the onset of symptoms can be pretty quick. You get a fever, there's a rash that kind of looks like a sunburn, and there's some other things. The shock can also lead to organ damage. A lot of it's associated with kidney damage and things like that. So it's serious, and it really does start with these little tiny microbes like strep or staph that get or release toxins that cause our body just to react in a very strange way very quickly.
And so that can happen with misusage.
Yes.
Or overusage.
Wearing a tampon too long is usually what's associated with menstrual associated toxic shock syndrome.
Okay. Representative Taylor to end this discussion.
We will. Thank you, Madam Chair. Actually, this is a very, it's nice to talk about issues, but this is a very important issue. And at the appropriate time, I'd like to make a motion to move.
Well, unfortunately, it's too late to, well, it's really not too late to move on it. Okay, we've got a second. Does it, but in this, now wait a minute, let me get it clear. I don't remember from reading it. Does it require that the doctors?
No, it is
it's
an
okay.
encouragement.
Right.
Okay. All right. I'm going to let this committee do what they would like to do. At this time, we have a motion of due pass and a second. Further discussion by the committee. Okay, anybody in the audience left that would like to still say anything? We got anybody from the department? Then- Okay, then we got the up on it like this. Okay, so hearing none, everyone in the favor of the passage of House Bill 358, say aye.
Aye.
Anyone opposed? No. I think the ayes have it. Will you please let Representative Bazemore know that as soon as you can get that? And thank you for our step. That I'm sure that you tell her tell her that this is our bouquet of flowers to her. Okay, thank you.